My name is Dr. Stephen Paget, and I'm the Physician-in-Chief and the Chairman of the Division of Rheumatology at Hospital for Special Surgery. I'm pleased today to introduce you to Dr. Robert Lindsay, who is a professor of clinical medicine at the Columbia Presbyterian Medical Center and also the Physician-in-Chief at the Helen Hayes Hospital. He's an expert and world famous in the area of osteoporosis. Dr. Lindsay, thank you for joining us today, and I have some questions for you. First, what is osteoporosis?
Osteoporosis is a disease of the skeleton in which there is insufficient bone in the skeleton to withstand the stresses that you and I might put on it every day. The consequence is that bones are likely to break or fracture, and fracture is really the only clinical important feature of osteoporosis.
Is there anyone who is not at risk for the development of osteoporosis or bone fractures?
Well, eventually, if everyone were to live long enough, we'd all get osteoporosis. But the groups of individuals who are most at risk are women after the menopause, particularly Caucasian or Asian women, and patients who are put on glucocorticoids or steroid therapy. Those constitute the two highest risk populations.
How does one measure whether you have an increased risk of developing fractures or the development of osteoporosis?
Well, fortunately, today we don't have to take a piece of the skeleton out and examine it under a microscope as we used to in the past. There are well-developed techniques called bone densitometry that allow us to measure the skeleton with a high degree of accuracy and precision. There are many different techniques available. The workhorse is a technique called dual energy X-ray absorptiometry, which measures bone primarily in the spine and in the hip, which of course are the two sites that are of major importance in terms of osteoporosis-related fractures. But any test can measure the risk of any fracture.
What are the risk factors for the development of osteoporosis or bone fractures?
I think one of the things we've discovered from the controlled clinical trials that have been done is that if you look at the placebo-treated population, then you find that when people have new fractures, they're at high risk of fracture, especially in the year following the fracture. We found, for example, that about 20% of patients who have a vertebral fracture are likely to fracture in the next year. We also know from the same controlled clinical trials that if you introduce a therapeutic agent, a drug, then you get a treatment effect in all populations. However, because of the increased risk that is associated with the fracture, even when there is a treatment effect, you can't reduce the risk back to baseline. So the critical issue for both physicians and patients is establish who's at risk for this disease, and if you believe they're at risk, get a measurement of bone density to determine the real risk of fracture, and try and intervene before fracture occurs.
Are there effective medications these days for the treatment of osteoporosis or its prevention?
One of the things about this disease that's really developed in the last 10 years has been a variety of different medicines that affect the skeleton. And those can be broadly divided into agents that have multiple effects in the body, such as hormone replacement therapy, tissue-selective estrogens or selective estrogen receptor modulators, as they're sometimes called, and agents that affect specifically the skeleton, such as bisphosphonates and calcitonin. So we have a variety of choices, all of which are effective in the reduction of vertebral fracture risk.
How does the physician and the patient decide which of these medications to use?
Well, the nice thing, of course, is that they all work. That's a good starting point. And clearly, when you have agents that work and you have choices, then you have different horses for different races. Hormone replacement therapy is most commonly provided for people who have menopausal symptoms and clearly is the treatment of choice for that. The side effect of that is that you're getting prevention of osteoporosis at the same time. In the older individual who has osteoporosis, the physician is more likely to want an agent that specifically affects the skeleton. And here the bisphosphonates become particularly important. In the sort of middle group, for the postmenopausal population, that is women who are asymptomatic, probably between the ages of 55 and 65, but who have peers who have developed breast cancer, these are people who are more likely to seek out agents such as raloxifene or tissue-selective estrogens because those agents seem to reduce the clinical appearance of breast cancer as well as preventing bone loss.
Since we have two effective bisphosphonates, how does one choose which one in a given patient's problem area?
For people who have significant osteoporosis, then bisphosphonates become the most important drug of choice. One would use one or other, dependent on perhaps on the patient profile. For people with upper gastrointestinal disease, you might, for example, be more likely to choose risedronate over alendronate. For people whose profile is such that they can't get up early in the morning to take these drugs fasting as they have to and then stay up and wait for half an hour more until breakfast, you might choose a drug that you need only give once a week, such as alendronate, for example. So I think that between the bisphosphonates, there are clear choices depending on the patient profile.
Do physicians use combinations of anti-resorptive agents? And if so, when?
I rarely use combination therapy because there are no fracture data demonstrating that combinations give a greater effect on fracture than each individual agent by itself. Where I sometimes get pushed into combination therapy is when a patient fractures on the therapy that I've begun initially. Why does that happen? It happens because we know that these agents reduce the risk of fracture. They don't eliminate fracture. But to the patient, if they fracture on treatment, that is a treatment failure. And often the patient will come and say, this treatment is not working well. I've had a fracture. What are you going to do? And in those situations, I sometimes will say, well, we can either change the therapeutic option that you're on, or we can add in a second treatment to see if we'll get a better effect.
Are there new drugs on the horizon that are even more effective than the ones we've already discussed?
I think the exciting thing for the future is that we are beginning to see the development of agents that don't just stop bone loss like our current medicines do, but agents that actually build new bone. We've been involved for a number of years with parathyroid hormone, which is currently under development for osteoporosis treatment. Parathyroid hormone stimulates bone formation. Parathyroid hormone may not be the ideal drug for osteoporosis because it's an agent that currently has to be given by injection on a daily basis. But what parathyroid hormone tells us is that here's an agent that will build new bone, that will change bone mass to a greater degree than any other agent that we have, will correct the underlying architectural problem that we see with osteoporosis, and may point the way in the future to a cure.
Isn't the treatment of osteoporosis, like all components of medicine, related to an excellent relationship and partnership between the patient and the physician?
Absolutely. These are medicines which are being used for a chronic disease. And we've learned lessons from the treatment of other asymptomatic diseases such as hypercholesterolemia or hypertension. Now, what you really need is a good understanding by the patient of what is being tried, why it is being tried, and the importance of sticking with the treatment. And then the physicians have an understanding of the pathophysiology of the disease and what the medicine will really be doing for the patient and what the patient can expect as an outcome. And once that relationship is established, then I think we have medicines that can significantly affect not only individual patients, but also what has become a medical emergency, if you like, and that is the major public health problem of osteoporosis.
Dr. Lindsay, thank you so much.
Thank you.